Good afternoon. Ready to start this session that has three portions. We're going to talk about left main and multi-vessel disease, updated concept and treatment. My name is Yeung, and together with me is Duk-Woo Park. Our panelists are Ziad Ali, Adrian Benning, Scott Harding, Mamas, Yoshinobu Murasato, Bruno, Scheller, and Pieter Smits. So let's get started with the first presentation. SJ Park, is SJ here? So SJ is going to talk about revascularization. Going to talk about revascularization for left main disease, updated data, global guidelines, and beyond.
Thank you. Good afternoon. All right. Briefly review, the concept, updated data, global guideline, and beyond. The revascularization for left main disease, focus on the left main, PCI versus bypass surgery concern, recent meta-analysis of four randomized studies, syntax, precumbent, novel, Excel study clearly demonstrate all deaths between the bypass surgery PCI, not significant different. And stroke, early higher incidence of bypass surgery, however, no difference. Is higher procedural myocardial infarction in bypass surgery and higher spontaneous MI in PCI. That's a difference. However, hard endpoint all deaths is absolutely no difference at all. If you look at the 2021 ACC guideline, main disease, if you look at the high anatomic complexity, if suitable, candidate for bypass surgery, still bypass surgery is standard treatment. However, low anatomic complexity for those patient group, PCI would be class 2A, indication is still 2018 AES guideline, lower intermediate syntax score docile would be candidate for PCI. What does it mean? High anatomic complexity or high syntax score. If you look at in main disease with concomitant three-vessel disease can make a high syntax score. It's totally different. If you look at the main disease, very a little bit different. Anyway, around 60%, more than that, patient of the main disease would be candidate for PCI. So we know that main disease is not surgical disease anymore. So I would say practical guideline for the main disease, main with extensive non-main coronary artery disease, high syntax score is present. Bypass surgery may be preferred. Main with low anatomic complexity, low and intermediate syntax score is present. PCI better. Multiple comorbidity concern, PCI may be better. Right. Recent changing concept and technique for the main PCI. Main disease, the big vessel proximal lesion and short lesion length is really good target for PCI. And so recently, we would define contemporary PCI, physiology and imaging supported PCI can make a little bit different, clinical outcomes. FFR clear 1A guideline. Look at this. This is non-main stenosis, more than 1,000 lesions. Look at this. More than 50% diameter stenosis, significant stenosis, but negative FFR. What do you think? So more than half, 57% of lesions, non-main anyway, so negative FFR, and 16% reverse mismatches. The meaning is more than 50% stenosis, almost 60% of lesions are mismatched in negative FFR. So I would say, don't believe your eyes. And so anyway, imaging guided clearly has a better survival. This is large registry data. Our main compare 10 years follow long-term data. Even hard endpoint tests are totally different. And so imaging guided PCI has better survival. Right. If you look at the technical point of view, ostial shaft main disease, mismatches, tighter stenosis and negative FFR is not too much, just like a non-main disease, a little bit different, 26% of mismatches. Look at this, insignificant stenosis. However, main shaft, positive FFR, the meaning is there are some ruptures, roughness concern can make a positive FFR. So we define reverse mismatches. Bifurcation left main disease, that more than 90% of main bifurcation is downstream disease combined the LAD and circumflex disease, and functionally, I would say kind of a single unit of disease, still, FFR work for evaluate to treat or not treat concern. Mismatches, if the main with the downstream disease, on board 29%, still 23% reverse mismatches. So we have to realize relatively high frequency of reverse mismatches in terms of the left main disease. The reason why big jeopardy myocardium, there are some unrecognized region-specific, some abnormalities may relate that one. Can you make a treatment decision by ISCHEMIA for the main disease? ISCHEMIA matched with FFR. This is relatively just this old data, 6 millimeter scale, matched with 0.75 FFR. This is our data, 4.5 millimeter scale. So anyway, we do implement this, cutoff value of 4.5, less than that ISCHEMIA, positive FFR 83%, very strong, positive sensitivity. If the region had a downstream disease, more than 6 millimeter scale, it's a negative FFR, 94%, negative predictability very high. Between the two, we have to consider FFR. Treatment, not to treat concern, So in detail, PCI, how do we do? 1 stent or 2 stent, normal or small diminutive circumflex less than 2.5 millimeter, just a stent crossover. True bifurcation, larger circumflex more than 2.5, 2 stent technique would be okay. Provisional, 1 stent. Look like bifurcation lesion. However, according to the IBS findings, normal looking circumflex ostium, we do just a single stent crossover. True angiographic bifurcation, the main disease, some disease, severe disease circumflex ostium, we have to do 2 stent technique, almost same, angiographic result. Exactly same. Negative FFR for the circumflex, positive FFR LAD, we do IBS image clearly show that less, plaque burden, no significant, not significant disease in the circumflex ostium. We did just stent crossover, very good angiographic findings we have. And so we have to realize many mismatches between the circumflex ostium sailing and FFR. Look at this. After the stent crossover, there are many, different morphologic compromise for circumflex areas. However, function FFR is all negative. Only significant, circumflex sailing is 7%. Actually, if you do kissing balloon inflation or not, actually no difference at all. Hard endpoint concern. If you touch, may increase TLR rate. And so, any morphologic, compromise, negative FFR is just leave it alone. True bifurcation, look at this, fractional mass, myocardial mass concern, any side branch actually more than 10% of fractional myocardial mass is only 20%. However, circumflex is always more than 90%, more than that one. And so circumflex artery is usually big enough, front 2 stent, strategy would be safe and good. We can avoid the risk of side branch closure. Clinical outcomes of 2 stent are good. So 2 stent would be better. And so any, whatever you use, 2 stent technique, post stent, minimal stent area is the only important predictor. So we published this data almost 10 years ago. 9 months restenosis rate less than 5%, 5, 6, 7, 8. However, recent Dr. We published another data. 5-year MACE rate less than TLR 5%, 6, 8, 12 millimeters, stent area. It's a bit bigger than that. So I would just skip very tough main disease, just 2 stent. Final kissing, we can get a very good result here. Final ISCHEMIA 7, 9, and 9 millimeter scale. So Revascularization, the main focus on the main disease is not surgical disease anymore. You have to realize that one, imaging and physiologic guided PCI can improve clinical outcome. Upfront system for true bifurcation would be safe and good. Thank you for your attention.
Okay. The second lecture from Dr. Sripal Bangalore and OMT first with ISCHEMIA trial. Okay, Bangalore.
Thank you very much. So we'll switch gears and talk about multi-vessel disease, and I'll try to make a case for how best to manage after ischemia trial. So these are some of my disclosures as it relates to this specific talk. Let's just summarize ischemia trial. So we randomized over 5,000 patients with the moderate severe ischemia. Patients were randomized prior to cardiac cath to invasive versus conservative strategy, making it the largest treatment strategy trial of stable coronary disease. We enrolled a high-risk group of patients. More than half of the patient had severe ischemia. And since we are talking multivessel disease, 3/4 of the patient had multivessel coronary disease, with half of them having proximal LAD disease and coronary CT. And if patients were randomized to invasive strategy, 80% were revascularized, 3/4 with PCI, and 1/4 of patients with CABG. So there were a good proportion of patients who underwent CABG in the ischemia trial. If you are randomized to conservative strategy at 4 years, 23% underwent revascularization, and most of it was for a primary endpoint event. And in terms of medication therapy, there was a high adherence of medical therapy. 95% were on a statin. 2/3 of them were on a high-intensity statins. The median achieved LDL was 64, and the systolic blood pressure was 129. And the patients who were not enrolled, if you had ACS within 2 months, or if you had low EF, or if you're very symptomatic, we excluded those group of patients and also excluded patients with severe left main disease. So let's talk about multivessel coronary disease and see what ischemia tells us in the management of these patients, and potential reasons to consider revascularization in multivessel disease, potentially to improve survival. Can we prevent cardiovascular events or improve quality of life? In terms of survival, so these are the results for the overall ischemia trial, both ischemia and ischemia CKD, invasive versus conservative strategy for the endpoint of all-cause mortality, no significant difference between the two groups. And in fact, the curves are superimposed. There is not much difference for the primary results. This is the result for ischemia extend, where we are following ischemia cohort, and this is the 7-year results. For all-cause mortality, this is the curves for conservative, this is the curves for invasive. Again, we see that no significant difference between invasive and conservative for 7-year rates of all-cause death. And the rate of all-cause death in this particular trial is around 2% per year. But if you look at cardiovascular death, the interesting then of invasive strategy results in a 22% reduction in cardiovascular death when compared to conservative strategy. And you can see that the curves start to separate around the 2-year time point and continue to diverge. If you ask the question, why did we not see an overall difference in all-cause death? Because the difference in cardiovascular death was counterbalanced by an increase in non-CV death. We are still working to figure out why there is an excess of non-cardiovascular death in the trial, but that's the equation in terms of where we stand. In terms of multivessel disease, let's talk about higher risk subgroup of patients. You know, multivessel could be 2 or more vessels. What about patients who have 3-vessel disease? So this is a paper which hopefully will be published soon, where we are actually looking at patients who had 3-vessel disease in the ischemia trial. And for the endpoint of CV death or MI, the curves do cross at around the 1-year time point. Here we show that revascularization significantly reduces CV death or MI when compared to conservative strategy. And we also looked at whether the difference is driven by PCI versus CON or by CABG versus conservative strategy. Here, comparing PCI versus conservative strategy, there is a high probability. The probability is over 95% that PCI reduces CV death or MI when compared to conservative strategy. If you look at the endpoint of all-cause death, the curves are superimposed. There is no difference in all-cause death when comparing PCI versus CON in triple vessel disease patients. The probability that PCI will reduce events by at least 1% is very small. It's around 22%. What about CABG versus CON for endpoint of CV death or MI? Again, you can see there is an upfront risk with CABG, the late separation. The probability that CABG will reduce CV death or MI by at least 1% is around 76%. But if you look at the endpoint of death, the probability that there is a reduction in death, even in triple vessel disease group of patients, is very small. What about LV dysfunction? In ischemia, we did not enroll patients with EF less than 35% because that was answered in the STITCH trial and the STITCHES long-term follow-up. From the data from STITCHES, we know that CABG reduces, improves survival compared to medical therapy with a number needed to treat of only 14 patients. In the ischemia trial, we looked at the group of patients with an EF between 35 and 45 or who had a history of heart failure and LV systolic dysfunction. Interestingly enough here, and for the primary results, you can see that invasive strategy significantly reduces primary endpoint and also CV death or MI in the subset of patients with heart failure or LV systolic dysfunction. What about patients with diabetes? If you have patients who have diabetes and multivessel disease, is an invasive strategy superior? We published this in Circulation a couple of years ago looking at the diabetic subset, and here on the left panel you can see patients with diabetes who have multivessel disease. The red is for invasive strategy, blue is for conservative strategy. If you look at the endpoint of all-cause death, no significant difference even in patients with diabetes and multivessel coronary disease. Now moving on, what are the other reasons to consider revascularization in multivessel disease? Can we prevent other cardiovascular events? In the ischemia trial, we showed that invasive strategy increases procedural MI, but there is a significant reduction in spontaneous MI. And you can see that the curve starts to separate early on, more around the 1-year time point, and the curves continue to diverge. So there is a 33% reduction in spontaneous MI, and it's likely that this is what is translating into a decrease in CV death at 7 years of follow-up. We also showed from a number of other publications that invasive strategy reduces unstable angina and also lowers cardiovascular stays. And finally, quality of life. In the trial, overall trial, invasive strategy resulted in an immediate and durable relief in angina-related health status. So invasive strategy was superior compared to conservative strategy for angina-related quality of life. But this benefit was more restricted to patients who were symptomatic, but not in patients who were asymptomatic. So let's talk about the clinical implications for patient selection for multivessel coronary disease. I think OMT should be the background for most of these patients, given that atherosclerosis is a systemic condition. To improve survival in multivessel disease, there isn't a robust evidence that revascularization improves survival, except in those patients with left main disease or LV systolic dysfunction. Long-term follow-up of ischemia seems to point that there is a reduction in cardiovascular death with invasive strategy. Invasive strategy in multivessel disease also reduces spontaneous MI, unstable angina, and lowers cardiovascular stay, but the best benefit is for a faster and more durable relief of angina in symptomatic patients. This is reflected in the guideline recommendations, where if you're looking at survival as an endpoint, for 3-vessel disease, both CABG and PCI is a class 2B indication, so there isn't robust data that if you look at the survival as an endpoint, you're going to reduce survival. But there is a new class 2A indication that if you have patients in multivessel disease, revascularization lowers spontaneous MI, unplanned urgent revascularization, and also cardiac death. Thank you for your attention.
So we have a few minutes to maybe discuss these two talks a bit. Any questions? Maybe I'll start with, like, if you have one technique only to evaluate left main, what would you use? Meaning you cannot have.
Yes.
Well, I'll take IVUS, and I'll take IVUS because that's what I know best. But I would say, I would agree with Dr. Park. You know, I did syntax, I did Excel. Do I know more about treating the left main now than I did then? Colossally. And the data really is barely relevant. That, and the results that we get are so much better now that I think it's almost criminal to compare the two. And the other thing I would say is that...
Can you hear me?
I can. It's... is that we now can treat the left main safely. And as interventional cardiologists, we shouldn't be afraid to go into the main. And you see people doing proximal LAD and being frightened to put the stent into the main and getting a very poor result. If you treat the plaque disease or the obstructive disease completely, safely, and image it, that's doing your best job.
I actually got a question for S.J. Park. I very much enjoyed his presentation, and I think you made it very clear that if we have simple crossover, simple disease in left main, crossover is fine. If we've got complex disease, we're better off with two-stent strategy. I believe that. My question to you, and I think one of the controversies is, you do crossover. What should we do? Should we open the door, so to speak? Should we touch the circumflex origin? You showed some data in your talk that suggested maybe there was a penalty to doing that. I think it's easy when you have an elderly patient, maybe 80, you do the left main, very happy not opening the door, but you do it in a 50-year-old, different story. So I'd be really appreciative of your opinion about what we should do in that sort of situation.
Okay. From the beginning, anyway, I defined the case selection first, and truly circumflex would be, not too much disease, right? Diminutive circumflex. We don't care about that one. Immediately after, any situations, more angiographically, 80-90% stenosis. Actually, just only 7% had a significant, FFR positive. And remaining thing, short segment narrowing, small, jeopardy area is a negative. Functionally, it's not so good, not so, issues. And so, however, we have to define a little bit more. I have a big vessel, more than 2.5, I defined that one. And there are some disease, there are some technical, difficulties to maintain after the stent crossover. If the truly bifurcation disease, we do, upfront the two-stent. So in terms of lay outcome, our, big registry data, upfront the two-stent would be, almost comparable with a single stent crossover, even better than that one. And so we have some confidence about the two-stent from the beginning, right? Don't hesitate anything, right?
Ziad.
So I wanted to mention an analysis that we just published in Circulation Cardiovascular Intervention from the Excel study. So we assessed the impact of complete revascularization, used complete revascularization by anatomy, Jeopardy score, ischemia, and functional, and found that the only thing that predicted your long-term outcome was the Jeopardy score. And then what we found was that Jeopardy score was almost universally related to the proximal and ostial circumflex, such that if you left a 70% diameter stenosis at your end of your PCI, you had a 3.1-fold hazard of death and MI, hard endpoints. So I'm a little confused about the discordance about potentially leaving a tight stenosis in the osteoproximal circumflex after crossover stenting versus moving more towards a two-stent strategy, or at least ensuring that you have a minimal stenosis, because when we looked at the hazard for 50%, it was gone. And so that has to have a lot to do with the amount of myocardium at risk.
So Ziad, one issue in ostium circumflex, is the ability to image it angiographically well. I mean, that sometimes could be confusing, right? Really, what is the best view? Sometimes overlap, so that might be adding some uncertainty. Sorry, SJ.
I have a question, Bangalore. All right. That's really nice presentations. And your data is conservative group had a little bit higher frequency of spontaneous MI rather than. And however, all the big data, hard endpoint actually no difference at all, right? So spontaneous MI would be transferred to the hard endpoint death or just a soft endpoint, right? Is it right?
Yeah, that's a great question. So, what we showed was in the overall trial and also mainly in the 3-vessel subgroup of patients, we reduce spontaneous MI to a greater extent. There is increase in procedural MI. But we have also compared what is the prognostic value of procedural versus spontaneous. Interestingly enough, spontaneous MI more closely tracks with all-cause death than procedural MI. So I think one of the signals we are seeing at 7 years in ischemia is a reduction in CV death. It's likely because it's driven by a decrease in spontaneous MI that we are seeing that signal.
Very good. Any other questions or discussion point? Ziad, so one more thought about that issue is that how you end up in a 70% circumflex origin lesion has to do with what is your original strategy.
Of course.
And also whether you have imaged the circumflex. Meaning if I just blindly just do, hey, the circumflex is not very important, I just stand across it, and you would predict likely that I think it's okay because you didn't do anything. But if you image it before and know that the circumflex is pretty wide open, so angiographically look a little worse, may not make you do it. So I think every 70% circumflex origin disease is not the same. It's how you end up there, to me.
I guess one thing that I'd like to ask Dr. S.J. Park is, what is the role of drug-coated balloons? I mean, you've spoken very eloquently around drug-eluting stents in the treatment of left main. Are we there with drug-coated balloons yet?
Main, I missed your question.
Can we treat left main with drug-coated balloons and no stents?
That's Antonio Colombo sometimes decided just DCB the left main and no stent.
Yes.
I can tell you we are doing this on a frequent basis, but only for the distal left main. The ostial left main requires stenting, but the distal one is fine with DCB.
And based on the data still, I don't believe too much about the DB. If vessel size is big enough, at least more than 2.5, I personally I think it's a stent would be better than the NADB concern. So main disease, I prefer stent even in the circumflex. And circumflex ostial concern. Look at this. And when he started, a large registry data, we do 6 months, 1 year follow-up angiogram a lot. All time ago. How recently you did? If there are some restenosis over there, symptomatically patient absolutely no, free of symptoms, quality of life is good. So is it not I think it's not a big deal, All right, that's a little bit different point.
Okay, thank you.
Okay, thank you so much. We'll move on to the next session, which is a debate. PCI versus surgery, left main and multivessel disease, updates on revascularization strategy in 2024. So we'll lead with the first side of the debate is PCI is enough when PCI should not be standard.
Okay, thank you. So might be the David Haggard is now participating ATS meeting and in the virtual joining. And so my topic is about the PCI enough when PCI should not be standard. The treatment is title is so challenging. This is my disclosure. So and this title is regarding the SAVA and TAVR is very challenging. Which patient with AS should be referred to surgery rather than TAVR procedure? That means TAVR is a routine and default strategy for all-comer severe AS. I think interventional cardiology doing the PCI like this, title is which patient, left main or multivessel, should be referred to surgery rather than PCI. This is absolutely PCI could be routine strategy for in contemporary the practice. So, and we have two very different procedures for left main multivessel disease, bypass surgery invasive and less invasive PCI. So, and this article is written by the cardiac surgeon Mario Gaudino. Over the time, there is key milestone for advancement in bypass surgery and PCI. So over the time, PCI treatment effect much improved and the gap has been narrowed. Also, as shown the ISCHEMIA trial, there are many recent advancement over the time is the drug therapies, ANI and the SGLT2 inhibitor, GLP-1 agonist, and the antithrombotic. We have many very nice drugs. So, and as a PCI for bypass surgery left main disease, as shown at Sripal, current most updated guideline in the US is just the PCI for left main is 2A recommendation. Bypass surgery is class 1, and most available data is we have a 4 clinical trial, longest follow-up, and the syntax left main pre-combat XL noble trial, just the exam noble trial in terms of primary endpoint is comparable outcome. And a couple of years ago, and this is IPD meta-analysis showing all-cause deaths. It's a 4 trial, no difference at all. And the most important endpoint, cardiovascular mortality, syntax score less than 33 is quite comparable. Even more 45 is bypass surgery was better. So, and as everybody know well, mortality difference, no PCI is associated with lower periprocedural complication. Bypass surgery can reduce spontaneous MI and repeat revascularization. So in the updating, most updated recommendation, the last year ESC meeting, ESCTS, just a little downgrade, and the prior syntax score, low syntax score PCI recommended class 1 is now most updated ESCTS recommended 2A recommendation for left main disease, and this article is emphasized that some part should be considered PCI, some part should be considered bypass surgery. Also, we also think about another part and family support and the socio-economic status and availability. So, and another part is about the multivascular disease PCI versus bypass surgery, and the available the longest follow-up study, the syntax trial, best freedom, and the most recently FEM3 trial, all trial consecutively showing the bypass surgery was better, and the primary endpoint, the most trial including repeat revascularization. So, and the current recommendation, just ejection fraction low, less than 50, 3 vascular disease bypass surgery is better. This is mainly based on the Stitch trial as shown the Bangalore, and just the ejection fraction is nearly normal. 3 vascular disease bypass surgery PCI just 2B, and this is mainly based on the ISCHEMIA trial. So what are next? What are we should expect? There are many new concept of state-of-art PCI that we now in the contemporary PCI, widespread use of imaging and physiology concept, and the drug-eluting stent technology is very good, also combined with the TCB, and the advanced new PCI technology, and the evolving OMT, also patient-oriented decision-making with the evolving algorithm, risk score, sometimes AI-assisted, and the precision medicine for left main PCI and multivascular disease, and we can widely use the physiology and imaging concept. And if you do and the IBUS imagination, and you can decide the treatment strategy. This is a very well-written review article in the cardiac surgeon, Dr. Christopher Marlace, and also, in the last year ESC meeting and the last year ACC meeting, a lot of important trial was presented in major article, Innovate Complex PCI trial, showing the compared to angiographic guided and primary outcome is good. Even left main disease and the very excellent result imaging should be done. And the October trial is a left main involvement, 20% left main disease. Also, this study shows that regardless of left main or no, and the consistent finding was observed. Our Octopus trial is also showed OCT and IVUS was quite comparable, and the major subgroup analysis, even left main disease OCT and IVUS shows comparable result. And as shown in our first live case demonstration, we are conventional thinking of a significant left main disease, and the lumen diameter reduction more than 50% is like a left one. And this article recommended another treatment pathway. Some left main disease we can do favor OMT, and some patients do PCI, some patients do bypass surgery. Still, we don't know OMT permit the safe deferral of revascularization for left main stenosis less than 70%, more than 50%, and that this is shown SJ, and we are practice really some proportion showing the visual functional mismatch, and don't believe your eye too much. And so this review article, Christopher Marley's and FFR and left main stenosis, more 70, we consider directly revascularization. Left 70%, you can use FFR or IBUS the imagination. That was the rationale of our main trial. Also, remaining issue about the multivessel disease, and some trial is ongoing, is like a low ejection fraction multivessel disease, head-to-head comparison, PCI versus bypass surgery, Stitch 3C is ongoing, and the contemporary PCI versus bypass surgery, diabetic patient, absolutely we need more data. And over the last 20 years, consistently bypass surgery is class 1, is PCI is the class 3, class C, and this is mainly based on the Body 2D and Freedom trial. This is very old data, is nearly 10 years ago, and no use of imaging and physiological concept, and just use primary, the first generation drug-eluting stent, and no adaptation of any SGLT2 inhibitor, GLP-1 agonist, no concept of the high-dose statin. So, and that is the main rationale of we designing new trial, defined diabetic trial, and is randomization is a contemporary state out of art PCI, updated CDMT versus standard bypass surgery. This started, the funding was completed, is now launched. And this is my summary. Left main multivessel revascularization, still debatable topic, although RCT guideline is crucial inform clinical decision, and the in-law patient just reflect a small proportion of encountered in clinical practice, and clinical circumstance very diverse, and the state of art PCI and the make treatment effect of PCI comparable to bypass surgery. Some important issue should be confirmed for the new random trial. Thank you for your attention.
So the next one is a recorded lecture by David Taggart. Surgery is still better. PCI would never surpass CABG.
Thank you. It's David Taggart here. I'm sorry I can't be with you today, but I would like to thank Dr. Duk-Woo and Dr. S.J. Park and the organisers for this invitation. And I've been asked today to talk about surgery is still better, PCI will never surpass CABG, and my conflict of interest here is clinically as a cardiac surgeon. So, I'm going to start with this quote from Marcia Angel, former editor of the New England Journal of Medicine. And she said, conflicts of interest and biases exist in virtually every field of medicine, particularly those that rely heavily on drugs or devices. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. And that statement is particularly relevant to what's been happening with PCI and CABG. 3 other cautions are, however, we need to look carefully at what patients are in the trial, because they often don't represent routine clinical practice. We must have a minimum duration of follow-up of at least 5 years, because almost every study of CABG and PCI show that the survival benefit of CABG continues to grow with increasing duration of follow-up. And we need to try and ensure CABG patients also receive optimal medical therapy in the same way that PCI patients do. And a final tip is always look at results and tables before you read text, because you should then be able to work out what the text will say. because often the text will have a pro-PCI bias. So I'll go back to the syntax trial of 10 years ago now, where in almost 1,100 patients, those randomized to CABG had a significant reduction in mortality, cardiac death, myocardial infarction, and the need for repeat revascularization in 5 years. And syntax also showed us the importance of the syntax score, in that in the low syntax score, the mortality benefit of CABG was 1%, in the intermediate group, 7%, and in the high syntax score group, 9%, and accompanied by marked reductions in myocardial infarction and repeat revascularization. And if you look at the syntax score out to 10 years, we can see there's a continuing benefit of survival in favour of CABG patients. And as many of these patients will have anticipated life expectancies of 15 to 20 years, this remains very important. Also, many of the cardiologists in this room took part in this study, looking at long-term mortality after PCI with drug-eluting stents, or CABG, in non-diabetic patients, and they concluded CABG, as compared with PCI with drug-eluting stents, significantly reduced the long-term risk of mortality in non-diabetic patients with multivessel coronary artery disease. And if you now look at the FAME3 trial, this was used to address two of the limitations that were perceived in syntax, that is, no use of FFR and use of an old generation drug-eluting stent. This had 1,500 patients, most of whom had syntax scores below 33, and the primary endpoint was 1 year MACE of death, MI, stroke, repeat revascularization with a wide non-inferiority limit of 1.65. But PCI failed to reach the criteria for non-inferiority. Now, if you look what's happened at 3 years now, in the reporting of this in Circulation in 2023, the primary endpoint as it stands was 18.6 for PCI and 12.5% for CABG. So the CABG was significantly lower hazard ratio for the primary endpoint. But in this presentation, the main endpoint has now been changed to a composite of death from any cause, myocardial infarction or stroke. So repeat revascularization has been removed. And this now seems to give a more favourable result for PCI with a hazard ratio of 1.3. So there were almost 40 authors in this paper, including statisticians, reviewers, and the editors of the journal. And the fact that this was allowed to be published like this was really quite surprising, with a change of the primary endpoint. If you look at patients with diabetes, then the FREEDOM trial showed very clearly the survival and continuing survival benefit of CABG out past 8 years, with the authors concluding in patients with diabetes and multivessel disease, CABG leads to lower all-cause mortality than with PCI and drug-eluting stents in the long term. That was despite the fact that these patients had relatively low severity disease. And the other thing FREEDOM showed us was that CABG was superior to PCI for every level of syntax score and should be the preferred method of coronary revascularization, regardless of the complexity of coronary artery disease. If you look at ischemic cardiomyopathy, the most definitive study was the STITCH trial, which in 1,200 patients showed a survival benefit emerging after 3 or 4 years and continuing to accelerate out past 11 years. Excuse me. In contrast, if you look at the recent REVIVE trial of PCI for ischemic left ventricular function, so PCI and optimal medical therapy were compared to optimal medical therapy in 700 patients with an ejection fraction below 35. And you can see that at almost 4 years, there was no difference in the primary outcome, the secondary outcome, or the individual components of death, myocardial infarction, hospitalization, or need for repeat revascularization. So no benefit of PCI in ischemic LV dysfunction. And if we now turn briefly to left main stem, I think the most definitive trial still published was the EXCEL trial, which at 5 years showed a clear survival benefit in favour of bypass grafting. And that was despite the fact that these people had relatively low or intermediate severity scores with syntax scores below 33. PCI resulted in a significant increase in the ratio for death, non-procedural MI, in repeat revascularization. And the initial comments of the New England Journal editor were, the finding of a higher mortality in one group than another in a clinical trial, unless the difference is clearly trivial, should receive central emphasis in the report of the results, and we would generally consider it important to include such information in the concluding statement in the final paragraph. But in fact, that was not done, and instead, it was concluded in patients with left main coronary artery disease of low or intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rate of the composite outcome of death, stroke, or MI at 5 years. And it then emerged subsequently that if you, rather than use a new biochemical definition of MI, if you go back to the third universal definition of MI, then the incidence of MI in the CABG group was reduced by about 3/4, which, had that been included in the primary outcome, would have overturned the negative finding of the Excel trial overall. And there have since been many attempts to try and overturn the results of the Syntax trial in terms of mortality. This study of individual patient data with 4 randomized trials, 4,400 patients, median age of 66, average life expectancy of 15 to 20 years, and a median Syntax score of 25, whereas in real clinical practice, 2/3 of patients will have Syntax scores above 32. At 5 years, no difference in the incidence of death, but a significant reduction in the incidence of spontaneous myocardial infarction and repeat revascularization in the CABG group. I would also point out this manuscript title gives no indication that the results are only applicable to about 1/3 of patients with left main, and it should have stated selected patients in the title. So there are 3 reasons for the persisting survival benefit of CABG. By placing bypass grafts to the mid-coronary vessel, this makes proximal culprit lesions irrelevant, and it provides prophylaxis against structured proximal disease. Secondly, the internal mammary artery elutes nitric oxide into the coronary circulation, and this has been shown to have a protective effect in reducing the risk of further disease. In contrast, drug-eluting stents can cause downstream endothelial dysfunction and create a prothrombotic environment. And the third difference is that for many patients, PCI means incomplete revascularization, and this has been repeatedly shown to correlate with the subsequent risk of death or MACE. So for these reasons, PCI is unlikely to ever match the results with CABG for most patients with left main and multivessel disease. In 2021, there was a debacle over the previous AHA-ACC guidelines when they downgraded CABG from a Class 1A to a Class 2B indication, and they did this without any new information. They referred to the ISCHEMIA trial, but it didn't compare PCI and CABG, and they left out a mountain of evidence showing the superiority of CABG over PCI. And for that reason, the guidelines were rejected by all cardiac surgery societies around the world. If we now look at the latest ACC guidelines, these were written largely by a group of cardiologists, pharmacists, lipidologists, nurses, lay members, but no surgeon and no surgical society was included. So, on that point, I'm going to conclude my talk. I'd like to thank the organisers, both Dr. Parks, for the great opportunity and privilege of coming to be able to deliver this lecture, and I hope to join you on the day virtually. Finally, I would like to thank the audience for your attention. Thank you.
So this debate is up for discussion. Anybody has comments?
So I'd like to ask someone, comment for the many, interventional cardiology Europe area is joining in this session. So, and as you mentioned, David, and last year ACC AHA guideline, the cardiac surgeon not actively involved. So I think the most recent European guideline 2018, but it's time to update it further. And what is think about this new guideline is a big change in the European guideline, the revascularization. Adrian, any thought about that? Yes.
There'll be new ESC guidelines this summer.
Yeah. Yes.
And we'll see what they show. The data is obviously similar to the data that was assessed in 2018. I think, to my mind, this debate, this kind of confrontation has run its course. I think we understand the benefits of surgery, and we understand the benefits of PCI. And I think for most patients, when we sit in Oxford and we discuss the case, we can decide between us whether it's angioplasty is best or surgery is best. That's partly looking at the angiogram, it's partly meeting the patient, and it's partly understanding the context of the discussion which we're having. And I think in truth, there are very few patients where it's a 50-50 call and you can't come to the best decision for the patient.
Yeah, I mean, I guess one of the questions that I would have is how important do we think that the endpoint of repeat revascularization is in making our decision-making strategies, particularly in that it's not really a spontaneous outcome. You know, it requires a decision by either the surgeon or the interventional cardiologist to undertake it, and it requires agreement by the patient, and the propensity to undertake it is much lower in PCI than surgery. I mean, is it important as an endpoint when deciding best strategy for patients? Maybe I can ask you and then Dr. Taggart as well.
So David is now is online joining.
Yes, I can see David. So I thought maybe ask you first.
Thank you. Good morning from the UK.
Yes, I can see you, David. So maybe
thank you,
Spencer.
Okay.
I didn't know if David wanted to respond. I was going to bring up another subset of patients that Dr. Mamas suggested that the surgeons are more willing to take on difficult things. I'm seeing a bit of the opposite. I'm seeing that there are surgical turndowns now that are going in large numbers, at least in our center, to PCI because they are judged to be prohibitive surgical risk. Now, there's no study that I know of prohibitive surgical risk with surgery versus PCI, and because of the word prohibitive, you might say there never should be one. It's prohibitive. But what is prohibitive? So there was a registry done of 700 patients that were judged to be a prohibitive risk for surgery. They had an STS score of 5.3, suggesting the 30-day mortality might be high for surgery. So they underwent PCI, and they had an actual 30-day mortality of 5.6, almost the exact same thing. So my question is, when you have these heart team discussions with the surgeons, some surgeons are motivated to say, this is really a high-risk patient. Maybe you should give it a shot with PCI. And I find the interventional cardiologist saying, yeah, it looks terrible, but we'll have a go at it. As the patient, I don't think that's where we should end up in the discussion. And I'm just wondering, is there any, you mentioned a study of abnormal LV, which is a guideline recommendation for surgery, but in practice, I find that the bad LV is often kicked over to high-risk PCI. Is there any way to study this issue, or is it beyond equipoise?
David, did you hear the question?
Yes, I did. Thank you. Excuse me, and a great comment. But all it goes to show is that surgeons use their common sense in conjunction with what the ESC-EACT guidelines say, that you can look at the anatomical complexity of disease and decide or think what might be the better interventional strategy. But if you've got a patient, independent of the anatomical complexity of disease, who's old, frail, with multiple comorbidities, surgeons use their common sense and say that theoretically this patient might benefit from CABG, but we know that the risk in this particular patient would be very high. So that means the surgeons are following the recommendations of the ESC-EACT guidelines. But that cannot be extended to lots of patients who are not high risk and who have complex anatomical disease who are being denied the benefits of CABG.
I might make a comment that to Mamas's question, we looked in the Excel data at the outcomes of patients who had repeat revasc, and their outcomes were bad. And it didn't matter whether they had bypass surgery or they had stents. Now, to me, that just means that there's a practical issue there. It might be that we assessed the disease poorly, or it may be that we did our job poorly, and that's surgeons or interventional cardiologists. But to try and make sure that our patients don't have repeat events, I think is terribly, terribly important when it's possible.
And if I can just support what Adrian's saying, I think this is one of the major reasons that what happened, as we saw in FAME3, that repeat revascularization was removed from the primary endpoint. So FAME3 changed its primary endpoint to try and favour PCI. And I think the real lesson from what Adrian is saying is that in future trials, the conventional wisdom that we can exclude repeat revascularization because it's not important is a true error of judgment. And repeat revascularization must continue to be included in primary endpoints.
Although I guess that would tend to favour any surgical intervention because the propensity to undertake repeat revascularization in someone that's undergone surgery is much lower than someone that's undergone PCI. And when you look at the mortality impact of repeat revascularization in Excel, that was only evident in the earlier time points, not in the later time points.
No, Dr. Mamas, that is not true. Well, that deleterious effect of repeat revascularization extended well beyond 1 year. So it wasn't just an early endpoint. It was an ongoing deleterious effect if patients needed repeat revascularization, whether by PCI or CABG.
Not if you look at the paper, anyway.
No, I'm quoting the paper by Dr. Stone.
Ziad.
Yeah, I mean, I think it's difficult with these certain endpoints for PCI to be CABG because the threshold to go for cath after you've had CABG compared to PCI is just completely different. This has been published in the New England Journal almost 15 years ago. The second thing which we haven't really discussed is rapid lesion progression after CABG, right? You put grafts on, there's rapid upstream lesion progression, and I think in many ways that favors CABG. The reason is you get preconditioning of those vessels, you get collateralization, so when you have an upstream plaque rupture, you don't get an infarct. But when those patients then end up not having redo CABG and coming for PCI, the PCI becomes much, much more difficult because now we have a much larger burden of disease. So as a result, using the same endpoints to compare these patients after their original event is very, very difficult.
I think that's particularly
Dr.
problematic.
I have to disagree with you there because surely what's important is whether you're alive or dead at 5 years. And all the evidence shows that if you have CABG, you're far more likely to be alive at 5 years, 10 years, and longer. So surely, whether we can talk about pathophysiological mechanisms, the key point is whether you're alive or dead. So saying that you're alive is far more important than talking about pathophysiological upstream effects.
David, how do we make sure that our patients get the type of surgery that they got in Excel? In the UK, the vast majority of patients get 2 veins and a single mammary. And Ziad's point is well made. If your vein goes down at 5 years, that's not the sort of surgery that we want our patients to have. Why can't we persuade the surgeons to do the arterial revascularization that was done particularly in the Excel trial?
Yeah. Great question, Adrian. And I think what is certainly happening just now in surgery around North America and Europe is there is a very dramatic increase in the use of multiple arterial grafting. So the message is actually finally getting home. But the other thing you have to be aware of, if you have a stent that goes down, the pathophysiological implications of that are far greater than a vein graft that goes down, perhaps because there was too much competitive flow. So there's a really big pathophysiological difference between a stent failing and a vein graft that fails through competitive flow. They have very different implications for clinical outcomes in the patient.
SJ, last question, last point.
Thank you. David, thank you for joining us.
Thank you for inviting me. Thank you very much.
Anyway, personally, I think the ISCHEMIA study is a turning point in any, PCI versus bypass surgery study. Look at this. Bypass surgery is better survival based on the very old data, CAS trial, STITCH trial, compare versus medical treatment compare. If you look at the PCI versus bypass surgery, it's old studies, old drug-eluting stents, no concept of, physiology, IVs guided, and so current guideline is based on the old data. So I think the ISCHEMIA study, multi-vessel disease, optimal medical treatment, lots of changes during the last 10 years, high dose statin, et cetera, and so from that point, we need absolutely, good randomized study, PCI versus surgery. Up to this point, even in the diabetic patient, look at this, very two study, freedom study, they use a Texas bare metal stent, nothing about any, contemporary concept. So still we said, surgery is better. And so I think just beginning from the ISCHEMIA study, we need more, data, PCI versus bypass surgery.
Thank you, SJ. So
let's Dr. SJ, with all due respect, I've got to completely disagree with you. You want new data? Well, look, we've got it. Look at FAME3. We're using the best drug-eluting stent. It's FFR guided, so it has addressed the limitations of syntax, and it still shows CABG to be far superior. And that's because I showed you the three pathophysiological differences between PCI and CABG. And these are things that a new stent is not going to fix. The second issue is to use the ischemia trial to downgrade CABG is absolutely ridiculous.
All right, David, I think we have to move on if you don't mind, because we have a bunch of cases. Thank you so much. I know
David,
thank you for the invitation.
Very passionate.
Thank you so much.
Here.
See you next year, David. Thank you.
I think one point I can conclude is do not study bypass versus PCI anymore. Because otherwise this debate would go on forever. All right, so the next section is about master's case and review. So case one is going to be presented by S.J. Park about practical issue of left main and multi-vessel PCI. Make it simple.
Okay. Anyway, we need more data. Practical issue. Global guideline, all right, we have already reviewed. 2018, it will be older. However, more than 60% of a patient would be candidate for PCI. 2000 ACCH guidelines, I have already, reviewed that. Class 2A, right? 2A maybe, some part of 60% of a patient. So I would say I've already reviewed that, extensive three-vessel disease, high syntax score, high anatomic complexity would be related with the multi-vessel disease, right? And sometimes we need, bypass surgery. However, the other cases, lower syntax score and the comorbidity, PCI would be good. All right. What about the multi-vessel disease? If you look at the ESS guy, just only, low docile, PCI, look at this, 1A, they defined anyway, to 2021, they defined, 2A something. Anyway, not too much indication. They clearly separate with the ischemic cardiomyopathy, is less than 50% ejection fraction, based on the large, STITCH trials, 5 years, 10 years. Anyway, bypass surgery would be better. However, in those cases, more than 50% ejection fraction, even three-vessel disease, including bypass surgery, PCI, any revascularization, 2B indication, right? So that is based on the data about the ISCHEMIA trial. The reason why I would say, from the ISCHEMIA study, we have to think about the new, concept, new, randomized studies. And so up to, Bangalore already reviewed all the things, no difference at all. Ischemic extended, 5.7 years, hard endpoint concern, no difference, medical treatment and invasive treatment. All right, so this is a case concern, practical approaches, multi-vessel, all ischemic region, symptomatic okay. Favorable anatomy, big vessel, PCI would be okay. Based on the current data, low ejection fraction, diabetic patient. We have no data, and so we're going to start in new, diabetic patient. 3 vessel, not to touch. Unfavorable anatomy, PCI, consider bypass surgery. However, look at that. Majority of multi-vessel disease, I would say, just based on the ISCHEMIA study, 1 or 2 high-risk major vessel PCI, prox LAD we can fix up, sometimes the 2 vessel, prox RCA, prox LAD fix up, and optimal medical treatment, we can do that. Just to mention, all the study used all the DS, no concept, back of concept of physiology imaging supported the PCI, something like that. And so we have to consider contemporary PCI, FFR guided, and I've supported new study. So just Duk-Woo, introduced, functionally, even in the diabetic patients, 3 vessel disease, we are going to do, compare with the PCI, doing PCI and bypass surgery. That is a defined DM study. And main study, even in the main disease, downstream disease, is multi-vessel disease. We want to fix up then. Last 3, even in the main disease, really FFR work or not, we want to evaluate that one. So, all right, practical cases. And so, ostial main shaft, I think, is 1A class. So just, stented ostial main is not too much, cases. However, it's really work very well. Long-term outcome is great. And just I mentioned about the bifurcation, 1 stent, 2 stent strategy. Absence of ostial disease, stent crossover is okay. Truly bifurcation disease, 2 stent. So others, exactly same cases, not significant disease, circumflex osteums can cross over, or front to stent. I would already reviewed that minimal stent area is very important predictor for restenosis rate, even clinical MACE rate at 5 years, 6 millimeter LAD, 8 millimeters remain, 12 millimeters is quite enough. So any bifurcation regions, we can do the fix of the multi-vessel, the other epicardial artery disease. Main bifurcation is really good target for stent procedure. I would say truly bifurcation by obvious finding, LAD ostium, circumflex ostium. We're going to do the, 2 stent, upfront to 2 stent, circumflex, stent 4, stent balloon crushing, and finally kissing balloon inflation. Just exactly same cases, this morning we've done truly bifurcation, 2 stent technique would be good. Finally, we have, optimized obvious, guidance. 3 vessel disease, just I suggest, 3 vessel, right coronary artery, intermediate synapses, diffuse long region, LAD here, circumflex distal, some disease, namely 3 vessel disease. However, RCA would be good. Circumflex distal, this is a functional, concept, small vessel territory. So we just focus on the, LAD, basically diffuse disease by obvious finding. And so we're going to fix up just the proximal area, 2 stent by just like a tandem concept. After the stent procedure, we don't believe too much about that. Anyway, far distal FFR is 0.91. So look at this. Even in the 3 vessel disease, fix up with a major vessel, so any diffuse disease, and combine the optimal medical treatment, I think it would be okay. So changing concept, main and multi-vessels, contemporary PCI imaging and physiology supported PCI can make a better clinical outcome. And major vessel PCI with optimal medical treatment would be appropriate approach for multi-vessel disease. Thank you.
Okay, we're gonna move to the second master's case and review, and Dr. Do-Yoon Kang is about the choosing widely FFR versus anatomy-guided left-main PCI.
Yeah, thank you. My case is the FFR versus anatomy-guided left-main PCI. The case is the 2 days morning live case. At the first session, the first case this morning. The patient has the intermediate left main disease. the 73-year-old female with a stable angina. In the spider view on the right side, it looks just like the mild disease. And in caudal view, there is intermediate stenosis on the left main. And cranial view, it looks just like that, about 50% stenosis with a significant mid-LA disease. So maybe I would treat the mid-LAD then, the proximal left main, that we should think so much about the treat or not to treat. And this is the case that we treated this morning. And what is the significant stenosis of the left main? As this left case, it's really significant. But right case, it's mild. However, there are so many cases in the gray zone. And significant left main disease was defined as the more than 50% diameter stenosis in the pre-combat trial, and 70% in the Excel trial, or 50 to 70% diameter stenosis with the hemodynamic significance. And in the previous trials, in the 1980s with the surgical trials, it was defined as a diameter stenosis more than 50%, and that shows the benefit of the surgery over medical treatment. And in those studies, even the more severe, more than 75% of the diameter stenosis showed poor clinical outcome compared to the less severe stenosis degree. And the 1970 study also shows that the left main diameter stenosis, 50 to 70%, was not very poor. However, the left main diameter stenosis more than 70% showed poor clinical outcome compared to normal or diameter stenosis 70%. Then what would be the good cutoff for the left main diameter stenosis? And also, intermediate left main disease in ISCHEMIA trial, as Dr. Bangalore published, they did not show no difference in primary endpoint. However, even in the intermediate left main disease, the spontaneous MI a little bit increased in the compared to the conservative the management. So the problem is that in coronary angiography, the left main disease is not very well evaluated with a poor reproducibility. This is very old study. However, and the percentage of the lesion missed by the segment was very higher in left main segment. The many disease was missed by the angiography. Then we now have the two angiography that which would be a significant stenosis. Left side, it looks very mild, and right side, there's some severe angle, but in angio, we don't know. Actually, we cannot know, and even in this patient, the QCA is impossible because there is no reference proximal segment. And we checked the FFR, and this region, FFR was 0.71, and right region, FFR 0.89, non-significant. We checked the IVUS. IVUS shows diffuse atherosclerosis from the left main to mid-LAD, and the vessel size is much bigger than lumen, and that would make some diffuse disease with the significant FFR drop. And in this region, there's some angulation. However, the minimal lumen area was large enough from the 8 to 13 that made the non-significant lesion significance. Then, is the coronary angiography accurate? There are about more than 30% of the mismatch in liquid left main coronary artery disease when compared 50% diameter stenosis to FFR 0.8. And because left main supplies larger myocardium than other vessels, more patients in left main than non-left main disease has significant FFR even in lower degree of the diameter stenosis. So there is some effort to evaluate the left main accurately with the imaging and FFR combination. We have published the data that comparing FFR and IVUS MRA in 4.5 square millimeter as the cutoff. And European data, LITRO study, showed the predefined MRA criteria 6 was where evaluated the FFR 0.80. Therefore, the 2018 ESC guideline is recommending IVUS to assess the severity of the unprotected left main lesion, considering those data that with good association between MLA and FFR. However, still there is some discrepancy between IVUS and FFR. In iLitro EPIC study, published in Circulation Intervention 2022, enrolled a patient with the intermediate left main coronary artery stenosis that showed about 1/3 of the patient has the FFR equal or less than 0.80. And even in patient with a larger MLA, more than 6, 20% of the patient had a significant FFR or the decreasement. And in about 1/3 of the patient with a small MLA, less than 6, had a negative FFR. Still, the significant proportion of the patient has the discrepancy with the IVUS and FFR result. So we have insisted that the combination of the FFR and IVUS for left main evaluation and treatment evaluate the significancy and decide to treat or not to treat by the FFR evaluation and treatment with the IVUS guidance with the optimization. And because the clinical outcome after deferral of the left main disease is not so poor, this is the combination of the 6 studies that reported the outcome of the left main defer. The all death was 2.6% per year and MACE rate was 8.2 years. And when compared to left main PCI study, the last pink the bar of the defer left main combination, the result was comparable with the PCI. So we would test the role of the FFR in left main to select the patient where for the defer and where for the PCI. This is a fate main trial that has introduced by Dr. Park, and FFR guided left main versus angiographic guided left main PCI will be compared with the primary endpoint of the composite of death, MI, hospitalization for unstable angina, heart failure, or cardiac arrest or RR at 1 year. We will include the 50% diameter stenosis or more left main coronary artery disease. And this is the conclusion of the today morning's live case. After treating the mid-LAD, FFR at proximal LAD was 0.79. And the IVUS showed a different story from the angiography. Angiography, it was the less than 50% stenosis, but in IVUS, there were a huge amount of the plaque with a maximum plaque burden 80% with a diffuse left main to proximal LAD stenosis. And this is the result after treating the main to proximal LAD disease also. So this is the final message. In the contemporary clinical practice, the goal of PCI is to achieve complete functional revascularization of ischemic territories. So the concept of physiology guided PCI also work in the left main PCI setting. For all borderline or intermediate left main coronary artery disease, we believe that it is strongly recommended to confirm physiologic lesion significance before treating with the FFR measurement. And with the fate main trial, we assume that the improved outcomes with the FFR guide PCI will the result of more judicious PCI, though just treating the ischemia producing left main coronary artery disease. Thank you for your attention.
So the next case will be presented by Dr. Bruno Scheller about challenging treatment in left main in-stent restenosis.
Yeah, thank you very much, ladies and gentlemen. It's a great pleasure being here. There are several risk factors known for the development of left main in-stent restenosis, and these are the usual risk factors we know also for other reasons why we have issues. The current 2018 new ESC guidelines recommend for the treatment of in-stent restenosis the implantation of a second stent or the use of a drug-coated balloon with the same level of evidence. What is the strategy from my point of view if you treat in-stent restenosis? Number one, you have to define the mechanism of in-stent restenosis, including imaging, of course, and according to the cause of the in-stent restenosis, you have to choose the right lesion preparation strategy. And our opinion is that if you have several quality criteria of your lesion preparation, which is usually accepted as the absence of flow-limiting dissections, type A and B dissections are fine, and you should achieve a residual stenosis of less than 30%, then there could be the use of DCB as a primary approach, and drug-eluting stent implantation for the treatment of in-stent restenosis only in the case if you do not fulfill this criteria of lesion preparation. These are the data of the Daedalus patient-level meta-analysis on the ISR trials comparing DCB with DES implantation for in-stent restenosis. And what you can see here, if you focus on drug-eluting stent restenosis, the efficacy of the stent-in-stent approach in terms of reduction of repeated TLR is significantly better than with DCB. On the other hand, there's almost a significant benefit in terms of hard endpoints, death or myocardial infarction up to 3 years when using DCB instead of a second layer of metal. Most of these trials, which were included in this meta-analysis, had no clear recommendations for lesion preparation and the quality of lesion preparation. And we know very well, for example, from these data from Korea, that if you achieve a diameter stenosis of up to 20%, if you size adequately the DCB, then you have very good outcomes with respect to repeated TLR rates. If you do not fulfill these criteria, the failure rate is very high. So this should be the goal. I have 3 short cases about left main in-stent restenosis. This was a patient with prior CABG. This was the rest of the saphenous vein graft. The lemur was already occluded. And he had this moderate in-stent restenosis. I'll go to the eye. Here this is a case which was done 8 years before from a colleague of mine who was not very focused in lesion preparation. Here you can see the huge amount of tissue that is in there. And he did a leisure job with lesion preparation, scoring balloon, non-compliant balloon, which was fine, but he did not his best in this case. Nevertheless, there was an acceptable result according to the angiographic criteria. But if you look here at the OCT, there is still a lot of tissue which is not been adequately pre-treated. Nevertheless, if you treat those lesions with paclitaxel-coated balloons, you have some gain over time, and this was 14 months later. Looks better in this angiographic view, and the FFR was 0.82, but not optimal treatment in this case. This is another patient also with in-stent restenosis, a little bit more severe, especially here in the proximal part, but also in the bifurcation. And this is in German, or the report, and the only thing I will tell you, those colleagues did a lot of lesion preparation, including scoring non-compliant balloon with high pressure and so on. And this was the result of the lesion preparation. It's acceptable by angiography. So they decided for a DCB approach, sequential use, first to the circumflex artery, then from the left main to the LAD. And this was the primary result, not perfect, but okay. And this is the 3 years follow-up angiography, which looks fine. So if you treat those lesions without additional stenting and using DCB, you can have some improvement over time. That's what we know from this. The last case is something which I think is very interesting feature of drug-coated balloons. This is also work here from Korea, from Professor Shin's group. They looked at the treatment of bifurcations with DCB if you only treat the main branch and leave, let alone the side branch. And what they could demonstrate is that you have an improvement of the origin of the side branch over time, even if it's not treated. And this is a case we did a few years ago. With this, there was a stent from the left main to the LAD, and we had this severe new stenosis now in the origin of the circumflex and this intermediate branch. And here, the ostium of the circ was treated with a DCB after lesion preparation. There was some carina shift into the origin of the intermediate branch, so there was some dilatation with an uncoated balloon. And this is the initial result after treatment of the circ, and you can see there's carina shift also in the origin of the LAD, and this was also treated with a 3.0 ultra-coated balloon. This is the final result, still some stenosis here in the circumflex origin, and this is 5 years later, and here you can see, especially in the non-stented area, the improvement of the origin of the circumflex and the intermediate branch. We have those cases have become rare in our lab because what we're doing meanwhile is to treat the distal left main with as less metal as possible using a pure DCB approach, and we have some non-randomized data about some early data, for example, here from a Chinese group looking at this concept with DCB only or stenting, and there are some signs that this may be a good way. Lesion preparation is still key here. These are data from Simon Eccleshall, from Thomas Rezan from Finland. One of the questions is how long should I inflate DCB? We know from the animal models that we have already with 10 seconds inflations in pigs the full effect. So I think it's feasible to go down to 20 seconds if you have issues with hemodynamics. So from my point of view, DCB should be the first treatment, also for left main in-stent restenosis, because it does not limit future options. The disadvantages in angiographic outcomes, and especially TLR, is related to the quality of lesion preparation, and this is key for success. You can repeat the procedure if you have a repeated intervention, and we have some potential long-term benefit on hard clinical endpoints. Thank you.
Thank you. Thank you very much, Bruno. And the last, the master's case and the multivascular PCI in HS, and Dr. Samir Mehta.
Thank you. Good afternoon, everyone. I'll start with case. So this is a 49-year-old male who presented with an acute inferior STEMI. The culprit lesion was in the proximal right coronary artery, was brought directly for primary PCI, and underwent successful primary PCI to the right coronary artery. But when we looked in the left system, there's significant non-culprit lesion disease. You'll see here proximal LAD, there's a very tight lesion in the proximal LAD, and in the circumflex, there's a more moderate lesion of about 70% in the circumflex. Now this case in our center was from more than 10 years ago, when there was a lot of debate as to what to do about this bystander disease. Remember, in the guidelines, not that long ago, probably just over 10 years ago, it was a Class C recommendation to revascularize non-culprit lesion disease. So we're basically saying don't do it based on registry studies. We subsequently had several randomized trials that showed a benefit of complete revascularization, and that became the standard. But what happened to this particular patient? So 4 years later, the patient has chest pain again, diaphoresis, calls 911, and an ECG is done on the scene. So how many of you think this time around the culprit lesion was that proximal LAD? Let me just see a show of hands. Okay, most. How many think it was the circumflex? Okay, and how many think it was the right coronary artery, the culprit? Okay, a little bit more, slightly more people for the LAD, and then about equal circumflex and right coronary artery. Okay, so this was the ECG at the scene. So it was another inferior STEMI. Okay, so it's an inferior STEMI. So how many think now it was the culprit RCA that was done? Hands up. Okay, and how many think it was the 70% circumflex? Hands up. Okay, so more for the culprit RCA. So here's the RCA. Wasn't the RCA. RCA is patent, stents open, perhaps a little bit of progression of the disease, particularly in the distal segment. and this is the left coronary system. So the 70% circumflex, the more moderate lesion, acute plaque rupture, and of course he underwent successful primary PCI. It's at this stage actually that he entered the complete trial and was randomized within the context of the complete trial. What about that tight proximal LAD lesion? Well, there it is, completely unchanged, tight 80% proximal LAD lesion. FFR in this lesion is positive. It's an 0.79 FFR in this lesion, but completely unchanged over a period of 4 years. So the question is, what do we do about this bystander disease, and do we understand this disease? And I will submit to you that we do not understand this disease. In complete, we did angiography-guided non-culprit lesion PCI as a staged procedure. We looked at hard clinical outcomes, CB death or new MI, and CB death, new MI, or IDR. We had 130 centers from around the world, and this was more than 4,000 patients, and we showed a benefit of complete revascularization. When you're able to do this and do it well, in this trial, we had more than 90% complete revascularization. I think that's really important to look in these trials, the proportion of patients that actually achieve complete revascularization. For example, in the shock trials, we're looking at less than 30% of patients had actual complete revascularization. In this trial, we wanted to prove the concept that complete revascularization reduces heart outcomes, and I think we did that fairly convincingly. In fact, the guideline recommendations shortly after this trial, taken into consideration with the other trials that were already done, gave it a Class 1A recommendation. Now, if you look at the revascularization guidelines, the HACC guidelines, you can count on one hand the number of Class 1A recommendations for PCI. This is now one of them, in addition to primary PCI and a couple of others. And the European guidelines followed shortly thereafter. They bumped it up from a Class 2A recommendation to a Class 1A recommendation. So there's unanimity across the world, really, on this, and this has now become a new standard of practice. So the question is, this is projected to increase the number of non-culprit lesion PCIs dramatically worldwide. And the question is that the right thing? And it may be the right thing to do in order to prevent heart outcomes. Except for this. This was a pre-specified analysis that we did in the trial. This was a large number of coronary angiograms that were read in the context of the complete trial looking at angiographic stenosis severity. And we found that essentially all of the benefit of complete revascularization was in the tighter non-culprit lesions. And one way to identify those lesions is using FFR. But the whole question is, as in the case I showed you, is it the stenosis severity or the ischemia causing potential of the lesion that causes future events, or is it the plaque morphology? Or perhaps it's a combination of both. So, if you look at it from a schematic point of view, on the far left-hand side in stable CAD, they're mostly fibrocalcific lesions. Physiology-guided strategy has been proven in this area, the FAME series of trials. These plaques are low risk of future plaque rupture. Most of the events that happen here are repeat revascularization. And then if you take the extreme on the right-hand side in the STEMI culprit lesion, here we have plaque rupture. I mean, nobody's going to do an FFR or physiology-guided strategy in an acute STEMI situation. And I use those two extremes on purpose just to illustrate the difference in the pathophysiology of this disease. It is the same disease. And then what about the non-culprit lesions? Well, they're kind of intermediate between the stable and the STEMI. And in the non-culprit lesion setting, about 50% of these lesions are unstable. Well, what did the data say? Well, there have been 2 trials that have compared FFR-guided with angiography-guided. The FRAME AMI trial was a Korean trial, and randomized 562 patients, and they showed a benefit of an FFR-guided strategy over an angiography-guided strategy. Whereas the FLOWER AMI trial, another large trial that was done, did not show a benefit. In fact, the hazard ratio here was 1.32, suggesting potential harm, versus the hazard ratio in the FRAME AMI trial of 0.43. So what is the right answer? Both of these trials were relatively modest, not definitive, probably won't change the guidelines, but we do need some definitive data, and that's going to come in the form of the COMPLETE 2 trial. This has already been initiated. We're looking at global trial, 5,100 patients randomized to physiology-guided strategy or an angiography-guided strategy. Physiology-guided strategy will use mostly a non-hyperemic index, although FFR is also allowed in this trial. And there will be a large OCT imaging study, the complete 2 OCT study of looking at 1,500 patients. And the primary outcomes will be looking at non-inferiority. The reason we're looking at non-inferiority is that we're projecting about 50% fewer PCIs in the physiology-guided arm versus the angiography-guided arm. If that in fact is the case and there is non-inferiority for hard outcomes, well, that will be a big win for patients, for physicians, and for the healthcare system. Again, we're doing a long-term trial. As Dr. Taggart correctly said in his presentation, coronary revascularization trials need long-term outcomes. That is when the events happen. You just have to look at the Kaplan-Meier curves in trials like COMPLETE. The events happen between years 1 and 2, 2 and 3, 3 and 4. So we're just having one look, and it'll be a long-term trial, 3.5-year outcome. And of course, we'll be getting a look at the plaques directly in 1,500 patients. This is going to be the largest OCT trial correlating the plaque morphology with outcomes ever performed. And we'll be looking at intracoronary imaging and looking to see which features of the vulnerable plaque predict coronary outcomes with a view toward ultimately performing image-guided PCI in these patients. Thank you.
So we have a few minutes for these case and review. Any questions, any comments? Yeah, Scott?
I was just actually wanted to ask Shamir, so it was a really nice presentation. The one thing you didn't talk about is the debate about when that revascularization should occur. Should it occur immediately in hospital? Should it be deferred? Is it safe to defer it? And if you're going to defer it, how long is it safe to defer for? Because that is another controversial topic.
Yeah, in COMPLETE, we showed that it was entirely safe to defer if you needed to. We stratified our randomization for very early, which is essentially the next day after the procedure, versus delayed, so they could bring the patients back at about 3 weeks. This was really center dependent, so almost all our centers in the UK, they could not do, the UK was the second highest recruiting country in the trial, by the way. They sent the patients home and brought the patients back because of the way they're reimbursed and other reasons other than the actual patient state. And when we stratified the results, there was a benefit regardless. And the reason is that most of the events that happen early are not due to the non-culprit lesion. I repeat, they are not due to the non-culprit lesion. They are due to the size and the severity of the STEMI event. Okay, and also complications with the STEMI culprit lesion itself, which is a thrombotic lesion. So it's not the non-culprit lesion that suddenly, it does happen, but it's rare.
Yeah, I get that, and COMPLETE did show that, but there is data from other trials suggesting the opposite.
Yeah, but the reason is that the issue with those trials is that there's no difference in mortality, first of all, and you cannot diagnose a peri-procedural infarction in an acute STEMI. It's almost impossible because the cardiac biomarkers are rising, whereas in the delayed group, the biomarkers have stabilized, so you can easily capture another event. So if you look, for example, at the BioVasc trial, there was only one event, only one MI in the immediate group versus many MIs in the delayed group. And this is a problem because that ascertainment bias is tied into the randomization itself. Okay. Right? It's baked into the randomization. So it's a very, very unreliable outcome to look at.
Pieter.
Shamir, again, a beautiful trial again that you're going to conduct. In the line of the previous question, when are you going to do the FFR in the FFR guided arm? Is that going to be at the moment of the primary PCI, or is it going to be staged? And I would suggest that you would also consider it doing acutely, because we know from previous trials that at least 1/3 of all the non-culprit lesions are FFR negative. And in many cases, you don't need to bring those patients back to your cath lab. Expose them again to contrast, invasive procedure, etc.
So we're giving centers the option of, when you do these large global trials, you can't just have one option because you have to adapt it to different country characteristics, reimbursement, practice patterns. So centers have the option, and again, we're stratifying the randomization to whether they want to do it as a single sitting, we are allowing it, or a staged procedure. 70% so far in the trial are staged, but we do have 30% that are doing it all in one procedure at the same time. So we have both.
Great. Great. And one more question. how do you see the latest full Revasc study results that have presented at ACC?
I think it was a well-done study. I mean, I'm interested to hear what your opinion is, having done Compare Acute. I think it was a well-done study. It was stopped prematurely, unfortunately. I do get the feeling in that trial that the patients were relatively low risk. And I am concerned that only about 18% of the lesions actually had PCI in the PCI arm, in the FFR-guided arm, which is a really low number, and there's very little contrast between the actual FFR-guided PCI arm and the medical management arm. So compare that with Complete, for example, where you had 90%, not only PCI, but 90% true complete revascularization, meaning syntax score 0. So there's a big difference in the revascularization rates. But having said that, I think they did the best with what they had. They prolonged their follow-up. They had enough outcome events to adequately assess their primary outcome. And all the PIs from that trial are on the steering committee of Complete 2, which is great. So they still want to study. We have a lot of centers in Sweden, Denmark, that did that trial. So
great. Perfect.
Thank you.
So as a summarize, I have one comment. I think your Complete 2 OCT trial is the trial design is similar to Prospect trial, would be some mainly target STEMI and non-STEMI patient. I think if you're going to do long-term follow-up, the result would be very, very interesting and informative. Also, very nice, good supplementary for our recent published PREVENT trial. It's a PREVENT trial that suffer from some low event rate and 80% in the stable angina. So after finding some important finding from Complete 2 OCT trial, you find some vulnerable plaque is for associate higher risk of some hard endpoint death or MI and the unstable angina, blah, blah, blah. What is your next step? You're going to do some design, some new trial like a PREVENT trial, or how do you think about it?
I can let Ziad comment on this as well because he's on the steering committee. But the issue right now is the intra-observer reliability of identifying a vulnerable plaque in real time is very low. We don't know exactly which parameters we should be looking at. And we don't have the ability to measure fine details like, fibrous cap thickness, for example, as accurately as we would like. Ultimately, this is going to be dictated by AI. AI will tell us in the OCT setting which plaque is at high risk, but we need these data first in order to develop the AI. The AI has come a long way, but it still has a little bit further to go. And by inputting all of this data, plus all of the other data that's been generated from all of the other trials, the AI technology will get pretty good. And then we will be in a position to do an image-guided PCI trial in these relatively high-risk lesions. Ziad, I don't know if you want to comment on that.
Yeah, so a couple things. First of all, I had the fortune of being the core lab director for Prospect, and your case was exemplary because the way lesions progress is not this slow progression to becoming progressively tighter, right? They stay very, very stable for long periods of time. Then you have a sudden, rapid lesion progression. And that rapid lesion progression is usually due to an intraplaque hemorrhage, or it's a burst of atherosclerosis like a pimple becoming hot. It's completely unpredictable. Now, what we know is you get more vasovasorum the more plaque you have, which is probably why the plaque burden turned out to be such a strong predictor in PREVENT. But having to track on what you said, I completely agree that AI is the most likely to be able to impact this. And the reasons are the following. Number one is all the trends are going in the right way, right? Pectosobs shows the same thing. PREVENT shows the same thing. Combine shows the same thing. They're all showing us if you have these vulnerable features, and like Sripal mentioned, if you wait long enough, and you mentioned, you'll get the events. You can't do a one-year endpoint. So I think what's going to end up happening is now that PREVENT has started this concept, I think using AI integrated into data sets like Complete 2 are going to help us make a definitive answer.
I'll just make one comment. There is actually a trial going on at the moment called Combine Intervene, which is actually looking at this question. So FFR negative, and actually they're using a slightly different cutoff, 0.75. They're also looking at interested about what is the right cutoff of FFR, and vulnerable plaque features gets a stent in a non-culprit lesion. So that's actually happening at the moment.
I think one question I have is that, when we look at patients, whether they should get PCI or get surgery, we sort of really take the patient out of the equation a bit, meaning after the treatment. So a lot of patients obviously are very compliant, able to change all the risk factors, and nowadays with PCSK9 or inhibiting the inclisiran and so forth, that really can get the LDL to 320. It's very different from a person that doesn't care afterwards, and those people should get bypassed because they have much better chance of survival, right? So I think a lot of trials, long-term follow-up, doesn't take that into account, as if everybody's the same after their treatment. So I think that's hard to control, but at the same time, from your practice, people that followed 10, 20 years, nothing happened because they have really, an LDL has been like 50, like solid, right? Versus people that, occasionally go stop their medicine, become LDL of 150. Those are people probably progressed and set up for vulnerable plaque, and I think we have a hard time controlling and studying that type of behavior.
Yeah, and don't forget, when you look for a vulnerable plaque, it's a snapshot in time. And then, a year later, that may no longer be a vulnerable plaque. So we know about 75% of those vulnerable plaques in the acute situation, stabilize. They become fibroatheromas. It's only about a quarter stay vulnerable beyond a 1-year time point.
Right. So,
that's what Alan says is so important, because that's what PREVENT showed. The curves separate, then they converge again. That's because you get new vulnerable plaques. And unless your medical therapy is really driving these LDL into the ground, although 80 was fantastic for a trial, unless it's 20, those are going to continue to occur.
Right.
And not only that, but now, we're going to have treatment for lipoprotein(a), and you've got to realize that's a really important risk factor for 20% of people in this room. So that's also going to make a significant difference to long-term outcomes.
And we knew this from very early on in the 1980s, is that you study endothelial function. It's not a stable phenomenon. It switches between lesions, and I think just that's biology, right? That never everything march together. That would be easy. Is some population get worse, some population get better.
So I think is talking about the next topic is about DCB role in the contemporary practice. Some different in Asia and the U.S. and European country. And Bruno Scheller, you published this very nice result in New England Journal of Medicine. It's a DCB used for ISR region, and then moved to small vessel disease, and then in European country now doing the native vessel, big vessel DCB versus stent. And then now in the U.S., they just approved the DCB for ISR in the presented the CIT meeting. Is now FDA just approved the DCB use. The adoption of the DCB in contemporary practice is very, very variable among the country. How do you think about? Alan, do you think about?
So when the DCB in the U.S. is priced as $5,000, it's somewhat difficult.
$5,000.
Yeah. So I mean, everybody is following the shockwave financial models that market as high as possible. Hopefully, the system will reimburse it, and therefore, at some point, get this hospital to get paid the money. So it's really a very perverse way of treating patients with this amount of charges of a balloon.
But as Bruno kindly showed that review we did of how to treat left main, and of course in the left main, what you don't want to do if your first stent is not completely expanded is to put another stent in without sorting out the problem. So imaging followed by appropriate therapy for the cause of the restenosis is the way forward, and DCB is a great treatment, particularly around the bifurcation, where there's just not much space.
Right.
I mean, we're increasingly using it in the UK for de novo lesions. So from the BSIS registry this year, I think 12% of all PCI was with DCB, 8% in acute coronary syndrome patients. There's been publications, so Simon Eccleshaw published a single-centre registry of DCB and ACS showing favourable outcomes up to, I think, 3 years in terms of MACE in JAK interventions fairly recently.
I'd like to comment on that. I mean, I really don't understand the DCB phenomenon that's occurring, right? I'm not saying they don't have their place, but you're talking to people that are saying, 20% of my cases, 50% of my cases are doing DCB. I'm doing DCB and ACS. Look at the data and for DCB and ACS. It's pitiful. And I'm not saying that in a critical way. I'm saying that there needs to be a better one. If you look at the trials that have been done in ACS with DCB, I'm talking about randomized controlled trials, They're very small, very few. That's what I'm saying. I'm not saying it's not a place, and I'm not saying there is, but we can't get people to adopt IVUS. There's truckloads of data that this substantially improves outcomes. DCBs are expensive.
They're not quite as expensive as that.
But why has the world rushed off and got excited about DCB and want to adopt?
May I give a short comment? I fully agree that we have not enough data so far, but things are changing. There are several large all-comer trials ongoing with DCB. Meanwhile, this is important to do, but the most important mistake was to focus on in-stent restenosis for this technology. And in-stent restenosis is the worst indication for DCB. DCB are a perfect tool to reduce the number and length of stents we implant in combination with stents. This will be the future, and we know that we have stent-related events over time, and the longer the stents are and the more stents you implant, the higher the stent-related events are. And if you can reduce this total amount of stents, then I think this will be a big step forward. And that's one of the reasons, I think, because people start to realize this advantage of DCB.
So look, I'm not disagreeing with you. I'm just saying that data is not the. I mean, look at the ISR Desire 3 10-year follow-up, right? So this was, drug-eluting balloon versus stent for in-stent restenosis. In fact, stents did better at 10 years. That was the data. I'm not saying that there's not a place. I use them for in-stent restenosis. What I'm saying is I'm not sure what's driving this very widespread use. Where people are using them in 30, 40, 50% of their cases, there is no data to support that at the present point in time.
So the question I have is that if you use DCB for de novo lesions, do you do IVUS for everyone afterwards?
No.
So why would you not run into acute closure that was 20 years ago that we were waking up in the middle of the night?
Number one, you need IVUS or OCT to optimize your stent. That's the reason why this is beneficial in stents. If you treat lesions only with DCB and look with intravascular imaging, it looks horrible. So this is number one. What's important is that we have to look not at the cosmetic result, we have to look at physiology in the future. And the reason why we do not see disclosures, number one, we select those lesions that require stenting by lesion preparation, and number two, we have dual antiplatelet therapy, which was not available in the earlier times of PTCA. That's a big difference.
And two other things. The angiographic quality is very much better. And second, the balloon properties and catheter properties are very much better. So I grew up with, restarting the list again at 5 o'clock in the evening because the old plain old balloon angioplasties are occluded. But I think it is different. I think there is a role for this technology in de novo disease, and we look forward to seeing the trials that will perhaps...
So maybe I can take a vote of yourself. If you have a proximal LED lesion, would you take a stent or would you take a DCB?
Prox LED, I take a stent every day.
Why not? Why not DCB?
Because it's my Prox LED. I've only got one of them.
In Japan. So the location, proximal.
For me,
it's
for
very
sure.
important, right?
For sure. No, let's not forget.
But some people are doing left main DCB.
Well, not
so I don't know.
Me,
I mean, even in ISR, the event rate is half if you put another stent. The question is what happens as you kick the can down the road, right? Because if you have restenosis or you have a target lesion failure after you've got a second layer of stent, everything is really bad. Mortality is high, repeat revasc is high, MI is bad. So that area is the unknown territory. Is it better for us to kick the can down the road and potentially get 85% instead of 93%? Or does the economics say, look, 93% of the time you put in a second layer of stent, they do absolutely fine.
And that was one of the interesting things about the ISR 3 trial, 10-year follow-up. They actually looked at the recurrent events. So they didn't exclude once you had one event. They subsequently looked at all the recurrent events. And what they showed us actually, some patients had up to 8 recurrent procedures on that one lesion. And your chance of having a recurrent lesion revascularization was substantially higher with a DEB than it was with a drug-eluting stent.
And eventually they did an IVUS, right?
Well, I don't know.
Comment on this side and we'll wrap up.
But I mean, again, it was...
But you have to be careful. There was no information which was the additional treatment.
No.
therefore, they couldn't say this.
Last question.
In Japan, the DCA combination use directional coronary and DCB is effective for the left main and the proximal LAD or LCX. In such case, directional coronary plaque burden reduced to less than 60% is effective to the efficacy of the DCB treatment, and stentless, no stent deployment in the left main or by side branch. So plaque burden is, the target is less than 60%. Not so much developing is not enough. So the DCB treatment is, in such case is very effective.
Thank you. Thank you. It's time to close, and a very nice discussion, and thank you, everyone. Thank you.
Wow.